Good morning, everyone. We're
Good
doing,
morning.
Good morning, Mr.
as Kathy mentioned, we're reviewing surgical wound classifications today. The reason we're doing this is there's been, well, a couple things. Obviously, it's part of our perioperative documentation, but also there's been a recent uptick in our infection rate, so we felt it was a good time to review this. A little later on this morning, Hillary Allison will be coming in. She is the infection control manager, and she's going to be talking specifically about some of the infections that we've had recently. So I believe there were 8 infections in December, I believe 6 in January. That's an uptick. We're usually around 2 per month. So, you know, in looking at our the infections that have occurred, it's very difficult to pinpoint any one particular area. And I guess, you know, surgical wound classification is part of that, but it's, so a good review of that I think will help us all maybe do a better job with that. Go ahead. So why do we determine wound classification? The CDC is who put this in place, and it's to determine the potential degree of microbial contamination. So wounds are classified according to the likelihood and degree of wound contamination at the time of surgery and the probability of an increased risk of infection. And it helps guide the surgeon with preventative measures such as prophylactic antimicrobials that they would select for, you know, for a course of action. So it's our job as the circulating nurse in the room to record accurate surgical wound classification. And really, I want you to think of it as, you know, start to finish. So you may start as one particular class, but you may finish as another, obviously. I think that's a very important consideration. As I was preparing for this, I was thinking back to the old days when we were writing using paper documentation, and it wasn't uncommon to walk into a room and see the paperwork 3/4 done before the case has even started, the wound class is filled out. That's not how we want to do it. We want to, obviously it's part of our job to pay attention throughout the surgery to see what's going on. A break in technique can change your wound classification. If there's gross spillage from the GI tract, that could change your wound classification. So there's a number of factors that can affect wound classification. So it's important that to understand that you may be starting as one particular class, but it may change during the course. And also, it's become everything has become value-based and what's the word I'm looking for? Outcome-based in healthcare. So if we have an infection that's directly related to us, in other words, a health-acquired infection, then Centers for Medicaid and will not reimburse us for those types of infections. So there is a financial implication. Obviously, there's a huge implication for the patient as well.
So they don't pay for the procedure that or whatever caused it, but they also don't pay for the treatment,
right?
Okay.
Which I think you'll see
Figure
a little
the
further
cost
on
of
is
a
very costly.
hospital-acquired infection.
Yeah, thank you. So there they are. I think we all know what the broad classifications are. You have clean, contaminated, and dirty. So the first one, which is hopefully our more common one, is class 1, clean. As you can see, a low risk of infection, 1 to 5%. We're talking about an uninfected operative wound in which no inflammation is encountered, and the respiratory, elementary, genital, and uninfected urinary tracts aren't entered. It's primarily closed. I found that interesting as I was reading about it. I guess I hadn't thought about the fact how do drains impact a wound. So if a wound has a Penrose drain in it, that is not closed, and that would change the wound classification. But if it does have a closed drain, so your typical bulb JP, a flat drain with a bulb on it, and it's closed, that would be still considered, it could still be considered a class 1 clean. So again, it's primarily closed, drained with closed drainage. And examples include inguinal hernia repair, ventral hernia repair, thyroids, exploratory laparotomy, and on that factor, laparotomies, laparoscopies, I've had people say to me, gee, I thought all laparoscopies were immediately a class 2, clean contaminated. If you're just looking inside the abdomen and you haven't resected the bowel, there's no gross spillage. If you're just looking, again, it's a class 1. That's a clean procedure until either you discover something or you perform an act such as a resection of colon or a resection of bowel. Mastectomies, neck dissection, total knee or hip replacement, craniotomy, laminectomy. Those are just examples. And we have laminated cards for each of the rooms that are going to go up today, actually, they'll have all of these examples just to help us guide and help us have a discussion with the surgeon. Ultimately, the surgeon decides what the wound classification is, but what we're looking to do is to have that discussion with the surgeon as to what they think the wound class is. And they don't always think in the same terms as us, so I think the laminated cards will help guide us all to more accurate wound classifications. So the second class is clean contaminated. So again, this would be ENT, GU, a lot of GYN procedures. So an operative wound in which the respiratory, alimentary, genital, or urinary tracts are entered under controlled conditions without unusual contamination. And it's important to remember that, without unusual contamination. Operations involving the biliary tract, appendix, vagina, and oropharynx, provided no evidence of infection or major break in technique is encountered. A little later on, I think I mentioned that Hillary Allison, who's in the back of the room, is going to be speaking with us just to kind of fill us in on what she does and how she looks at the infections for the hospital and different measures that we're all taking to try to decrease our infection rate. When I was speaking with Hillary, one of the things that was mentioned was, if there's a major break in technique, we need to be calling it out on each other. And I think, for the most part, I think everyone's good about that, but there's a human nature sometimes to be bashful, maybe for some of our newer perioperative nurses. You have to be willing to say, look, I believe you just contaminated yourself, Dr. Steve Scalia, and I'm going to need you to take your gloves off. I understand that puts us in a difficult position, but that's part of our surgical conscience, and it's an important part of the job that we do. So it's important that we be willing to call us out on that. I think when I was speaking with Hillary, orthopedics does a great job with that. I was working with Mark Kircher yesterday, and one of our nurses was close to a Mayo stand, and he immediately said, "Did you touch that? You were close." Always thinking of surgical infection, and I think it's reflective in his infection rate. So it's important that we all think that way. At the end of the day, that's what we have to do for our patient.
I think one of the things with that, if somebody says to you, you contaminated, you did.
Right.
There's no question
There's
about
no
it.
discussion.
Just take care of it.
Correct. Yeah, that's well
It's the
said.
easiest way to handle it.
That's well
None
said.
of us get mad at each other
Right.
for saying it. If it's,
Exactly.
You
And
think it happened, it happened.
truth be told, there's times you
Take
do
care of
and you don't realize it.
Exactly.
So maybe more often than not.
Right.
So examples again: bronchoscopy, laryngoscopy, cholecystectomy, open or laparoscopic, appendectomy, small bowel resection, gastrectomy, a TURP, cystoscopy, a Whipple, TAH, vaginal hysterectomy. Those are all examples of class 2 clean contaminated.
C-section?
Yes,
Okay,
C-section as well. Thank you. And again, there's exceptions to that. So, class 3 is contaminated. So now you have a greater than 10% risk of infection. That's even with antibiotics on board. So we're talking about open, fresh, accidental wounds, operations with major breaks in sterile technique, gross spillage from the GI tract. Actually, we had a case come up not too long ago with Megan involved, I believe. Megan was circulating, and there was gross spillage of GI content. And I had to go look at my notes to remember specifically what the wound class was. So I think originally the case would have been a 2, and it got bumped up to a 3 because of her awareness of what was going on during the operation. So very important line: incisions in which acute non-purulent inflammation is encountered. So that's kind of the key factor. So you may have inflammation, but there's no visible pus coming out of the wound or out of an abscess or whatever the case may be. So again, examples include, they mention open cardiac massage. Hopefully that doesn't happen too often. An appendix, if there's, again, gross spillage from the appendix. So an infected appendix where you see gross spillage of pus or it's ruptured would make it a 3. Bile spillage during cholecystectomy, that happens pretty commonly. And I would venture to guess that we are not changing our classification from 2 to 3.
You know, Mike, the appendix is always the question.
Yes.
Now, this, I think it would be a 3 if it was just inflamed.
Correct. Yes, I'm sorry. What did I?
You said it was ruptured.
Yeah. No, if it's
Appendix
ruptured,
can
I'm sorry.
go
It goes
3
up to
ways.
4.
That's
Yes,
one of
you're
the
correct.
ones they always use as an example.
Yes. Thank you. Thank you. Diverticulitis, dry gangrene tissue without infection. That was another example. You think of a gangrenous toe, you're thinking 4 immediately, but I believe if it's dry and it's not actively infected, that it's a 3. Okay. And again, if you have specific questions, perhaps at the end, Hillary can answer some of those. If I'm, if I'm a little, if there's anything that's gray to you, that might be a good opportunity for us to discuss that. So our dirtiest classification is class 4, and that's greater than 27% risk of infection. I had never seen the classifications written this clearly with the percentages of infections. I thought that would be interesting for all of us to understand that. So we're talking about old traumatic wounds, retained devitalized tissue, and those that involve existing clinical infection or perforated viscera. It suggests that organisms causing post-operative infection were present in the operative field before the operation. And that's a very important fact. So in everything that we're discussing, if we are able to make the case that there was infection present at the beginning of the case for whatever reason, or when we receive the patient, that's important for us to document, because that actually affects the entire course of the stay for the patient. And when we get into wound classifications, when we get into billing for the patient, if you can show that the patient had an active infection when they came to us, that protects us, because obviously they were at a much more increased risk of infection because of their previous history. If we don't have that information, then it looks like potentially the infection was caused or occurred on our watch. So that's a very important distinction. So examples of these types of procedures include incision and drainage of an abscess, myringotomy for otitis media, a perforated bowel, peritonitis, a gangrenous wound with purulent drainage. So again, pus that's present. I can't tell you how many times I've heard from our own, either Danielle or some of the people that are reading and looking at our documentation, how many times they've said, oh, the patient had an abscess and we put it down as a class 1. And this occurs constantly. So again, that's not, on our part, it's not paying attention to what's going on at the field. So it's an important piece for us to document. So what are we asking? What are we talking about? So we're talking about reviewing the patient's medical record. What we're looking for is, does the patient have currently any active infection? That's an important part of our job. So we're looking for existing infection. Are we aware of some of those key words? Perforated viscera. Was the appendix ruptured? Those types of things, so that we can, again, correctly document the wound class. Monitoring the progress of the operation. Again, looking for breaks in technique, looking for gross spillage of bile or of GI contents, paying attention to what's going on in the field. working with the surgeon at the end of the procedure to determine the surgical wound class. I venture to say that doesn't happen on a routine basis where we're actually having a discussion with the surgeon and saying, what is your wound classification? We're asking for the procedure, we're asking for, we're talking about the specimen. There's a lot of other discussions going on, but we need to have that wound class. Again, there's going to be times where it's open and shut case, you know exactly what you did, but I think it's an important discussion to have with the surgeon. And lastly, documenting the surgical wound classification in your perioperative record. And there's two places I believe that it comes up. There's one area where you put C, surgical record, or that's one place. And sometimes it's pre-populated in the other field. Yes?
So that's in the general case data where it says C surgical segment text, and then the procedure segment, it's gonna change, so it's not gonna be pre-populated. You're gonna have to
Right.
fill it out or you won't be able to finalize.
Excellent.
So that should be happening in the next week or two, hopefully.
Oh, excellent, excellent. So if you, hopefully everybody heard that, but Jen King just said it will not be pre-populated going forward. So obviously we won't, and you won't be able to finalize your record until you select that wound class. So again, I found this interesting, that wound classification does not deal, it deals with incisional infection, incisional infections. It does not deal like with burns. Those are outside the scope of wound classification. Again, some cases are more complex than others, so it's important to have that discussion. And some of the examples that they give are a wound with an open drain, as I mentioned earlier, laparoscopic removal of an ectopic pregnancy. If you're cutting across the fallopian tube, then it's immediately a 2. Was there infection present? A laparoscopic cholecystectomy, cystoscopy, if you're encountering infection coming from, if you encounter infection, which again occurs in a fair amount of cases, especially with stones. Amputation of a wet or a dry gangrene. So again, that difference between an active infection and an infection that has occurred in the past that we're treating, but it's not active at that time. Improper surgical wound classification may increase the patient's risk of infection and compromise the patient's return to health. So at the end of the day, that's why we're doing it. Obviously, that's putting our patients first. So I handed out this is a kind of a decision tree that I've handed out to everyone. So that's something for you as circulating nurses to keep in your pocket. It may help guide you through kind of that decision process. I'm not going to read through that, but I'll let you review that. As I mentioned, we also have laminated cards to put in all of the operating rooms so that we can help guide that discussion regarding wound classification. So here's some specific procedures where they get into some additional examples, and I actually meant to have this printed out for you as kind of a reference. I will do that later today. I'll get this printed out for you. So a C-section with long labor or ruptured membranes. Normally sections are classified as a 2, but if you have meconium spillage, then it moves up to a 3, I believe. Yes. Is that correct?
Yeah.
Yes, moves up to a 3. So that's where, Laura, you were asking if a section was a 2. So again, as we're doing our documentation, and that's an important, and the OB docs are very good about stating when there's meconium spillage. That's an important consideration for them.
And then if there's an infection, clinical infection, which could happen, doesn't happen very often with C-sections, could be a class 4. There's like an infection.
If there's an infection, yeah. Good point. I've never run into that, but of course that's a definite possibility. Circumcision, for Jeff Coiner, that's
Dirty.
it's clean. Jeff had asked me the other day about this specific
Unless there's an active infection.
incident. It was troubling that he was concerned about circumcisions, but it is considered a class 1. We don't do cabbages here, but those are considered a class 1. Again, if you're encountering bile, that would increase it. It could go from a 2 to a 3. If you're just manipulating the stomach, for example, but you're not resecting it, you could still be considered a class 1 procedure. So again, laparoscopic procedures can be a 1, can be a 2, and they can go up from there. Orchiectomy should be classified as a class 2 because the spermatic cord is severed. So that's another good example. Orchiopexy is a class 1. So again, sometimes it takes thinking about what you're doing a little bit. Not sometimes, it does take thinking about what we're doing. So again, Penrose drains, a surgical wound that is closed with a Penrose drain should be classified as a class 3. Clean wounds that are primarily closed and if necessary drained with closed drainage can be a class 1. So a Penrose drain is a form of open drainage. A pilonidal cyst with no inflammation or infection can be a class 1. Again, that's something that I would have considered more than likely to be a class 3 normally. But if no inflammation or infection is present, the excision of a pilonidal cyst should be classified as a class 1. If acute inflammation is present, it should be classified as a class 3 contaminated. If existing clinical infection such as pus is present, it should be classified as a class 4. Thoracoscopy and thoracotomy, can be, if you're just looking in, again, looking at the lungs, that's a class 1. If you're resecting the lung at all, then it becomes a class 2 or higher, again, depending on what you encounter. So just a couple of quick statistics, and then I'm going to turn it over to Hillary. 2010, 16 million operative procedures performed in the United States. Surgical site infections were the most common healthcare-associated infection, accounting for 31% of hospital-acquired infections amongst hospitalized patients. The CDC reported an estimated 157,000 surgical site infections. That was in 2011. So we've come a long way with, obviously, the procedures that we do with our technique, sterilization, prophylactic antibiotics. We've come a long way with all of that, but surgical site infections remain an ongoing issue in our field and something that we're looking to, obviously, continuously looking to decrease.
Good there?
What I just said.
Yep.
So, a couple quick things on preventing surgical site infections. This is not new information. Some of these are battles that we've that are ongoing with some of our surgeons, and some of it's in our control, and some of it, unfortunately, is not. But obviously we no longer shave in the operating room, but we do clip at this time especially for general surgery and vascular surgery. We're going to continue to fight that battle to try to decrease any use of even the clippers in the rooms, but we know that's an uphill battle. The best skin prep is any of the things that we have that are combined with alcohol. So chlorhexidine, gluconate, that has I believe it's like 75% alcohol in it, is our best prevention for skin preparation. Obviously making sure that we honor the time that it requires, the timelines that it requires for safety. Making sure that we're thinking about allergies for the patient and utilizing the appropriate product. And of course, antibiotic therapy. I'm not sure if everyone, I know everyone knows Vanco is 2 hours, but Levaquin is also within 2 hours is permissible. So I'm not sure if everybody was aware of that, but I spoke with pharmacy, and so Vanco I know is commonly known to be 2 hours prior to incision, but Levaquin also is in that category. Some of the other parts that are a little bit less in our control are operative blood glucose control. So talking about ensuring that our patients, that we know their glucose levels preoperatively, intraoperatively for long cases, as well as postoperatively. Same thing with normothermia, so keeping our patients warm before, during, and after surgery. These are very, very important parts that are linked directly to surgical site infections. As soon as the patient, any case of hypothermia directly increases the odds of that patient developing a surgical site infection. Same with blood glucose. For uncontrolled blood glucose, there's a direct link between uncontrolled blood glucose and an increase in surgical site infections. Oxygen, optimizing oxygen administration, also an important piece, and obviously anesthesia takes care of that for us. And another interesting fact that I found was that the use of impervious plastic wound protectors during surgery actually helped to decrease the odds of surgical site infections. I thought it was interesting that, especially with our general surgeons, some of our GYNs are starting to use the wound protectors as well, but there's a direct link between using a plastic sleeve and a decrease in surgical site infections. Okay. So I'm going to have Hillary come up and say a few words, and if you guys have any questions, I'll let Hillary speak and then think of your questions. She may be a better resource for answering your direct questions.
I decided to leave instead. I'm just kidding. Hi guys, I'm Hillary. I'm your infection preventionist. How many of you guys know who I am? Oh, that's not good. Okay, that's my fault. Clearly something I need to improve on. Everybody should know who your IP is in a hospital. If for nothing else, then I want you to feel comfortable to walk up to me and be like, hey, I have this question, or hey, I have this concern. All right, so surgical site infections started piquing my interest. By the way, I'm fairly new. I only got here in September. Not to justify the fact that you guys don't know me, but so in September I started doing system-wide surveillance for all surgical site infections, not just CMS related, which are, as they sit right now, they're looking to change it, but as they sit right now, total abdominal hysterectomies, hips and colon surgeries. These are the ones that CMS looks for to give us a star rating, which determines how much we get paid back financially from Medicaid and Medicare services. So I look at all surgical site infections, and I don't care what it is. It could be anything. If we cut into somebody, I'm paying attention to it. So our surgical site infection rates understandably went up due to increase in surveillance, but then in December we had this rash that was identified of surgical site infections, which is kind of why this campaign started of mass education. Let's just hit every field, make sure that we know house-wide what's going on. It's super important that not only you know what's going on, but that you know it's not your fault necessarily. Surgeries are top-down, right? So it could be risk factors from the environment. Maybe the room was too humid. Maybe the OR suite was too warm. Maybe we had too many people coming in and out of the space. Or maybe the risk factor was handoff. Maybe it wasn't necessarily something that happened in the OR suite. Maybe it happened when we were caring for them in recovery, not even just PACU recovery, but maybe it was on 4 West. Or maybe this was a factor that happened after they had left, after they went home. These are things that I look at from an epidemiology standpoint. So if I have somebody identified as a surgical site infection within 7 to 14 days, actually within 7 days, That's probably happening during surgery. That's just too quick a turnaround for bacteria to grow out. But we had a specific case for January, a laminectomy, that went home, and it was like 29 days before there was a surgical site infection. And you know 30 days is the cutoff for that surgery?
It's like when your warranty
Exactly, yeah.
expires in the next day.
The whole
right?
car broke down on day 29. But the risk factor for that